more minutes, we'll be ready to go.
Okay.
Did she get you squared away on the laser pointer? You got all that?
Okay.
Who called it? Claiming the situation was looking a little dire. You should do that for yourself.
12:04.
Are you with St. Vincent's?
Mm-hmm. Sure am.
This hospital or the other one?
The Birmingham,
Birmingham?
downtown. 25 years now.
Have you really?
Yeah.
Yeah, that's where my daughter was born 21 years ago.
My son was born 22 years ago there. No. Oh my gosh, 24 years ago there.
My daughter was I think she was probably the last baby born in the old.
Oh.
And
old
because they were
OB
actually
suites.
moving when my ex-wife now was
Yeah.
in. And the lady said, it's probably good that you're having her here instead of the new one. She goes, nobody knows where anything's at over there. She said, it's not as nice here, but she said, it'll be much more organized here for a while until they get everything going with it. It's a crazy hospital, all the adding onto it.
Mm-hmm.
Nothing's right angle. It's like,
Oh, I know.
it's a very odd hospital to navigate if you don't know your way around it.
Yeah. You want to turn me on?
Yeah, we get started now. All right, you are up and ready to go.
Can people hear me in the back? Okay. Yes? All right. I'm David Diatkin. I've been on staff at St. Vincent's Birmingham since 1993, so I'm one of the old guard now, but I'm usually here lecturing on a diabetes topic, but I thought we would do something a little bit more fun today and talk about diabetes or endocrine emergencies. Diabetic ketoacidosis will be part of it, but we're talking about some other things as well. I mean this to be informal. If people have questions during the talk, please interrupt or raise your hand, etc. And I'll try to leave some time at the end for questions as well. But I'm going to try to run through diabetic ketoacidosis, myxedema coma, thyroid storm, adrenal crisis, pituitary apoplexy, hypercalcemic crisis, and hypocalcemia in this short time. So let's start with diabetic ketoacidosis. A lot of you guys are residents, right? So what's the crowd here? I know some are just regular staff. We've got PT, who else? Okay. All right. So this is something that is seen in the emergency room all the time and is characterized by ketosis, acidosis, and hyperglycemia. And in the setting or in the era of SGLT2 inhibitors, there's 3 currently that are on the market, but these drugs are indicated for use in type 2 diabetes. You can have diabetic ketoacidosis if you have an SGLT2 inhibitor on board where you have ketosis, you have acidosis, but you have very little hyperglycemia. You can have a blood glucose of 150 and be in very bad diabetic ketoacidosis if you have an SGLT2 inhibitor on board. And so that's a very important pitfall to be aware of these days. Type 1 diabetes is the primary cause of diabetic ketoacidosis, but just because you're a type 2 diabetic doesn't mean that you can't go into DKA. If your insulin deficiency gets very profound, A type 2 diabetic can also go into diabetic ketoacidosis. And again, a type 2 diabetic that's on an SGLT2 inhibitor is more prone to diabetic ketoacidosis, and that's a warning for all those that are on those medications. So what is diabetic ketoacidosis? The central hallmark of diabetes is either relative or absolute insulin deficiency. In type 1 diabetes, you have an absolute insulin deficiency because the beta islet cells have been destroyed by an autoimmune isletitis. In type 2 diabetes, you have a relative lack of insulin, plus insulin resistance, plus exaggerated hepatic gluconeogenesis, et cetera, et cetera. So you have several defects in type 2 diabetes, but you do have a relative lack of insulin as well. So insulin deficiency results in hyperglycemia. Hyperglycemia results in hyperosmolarity. That in turn results in glycosuria, which results in dehydration and loss of electrolytes. And then you can ultimately develop prerenal azotemia and shock. On the other hand, insulin deficiency also results in lipolysis. There's a critical level of insulin where you drop below that and you start liberating lipids from adipocytes. The glycerol component of the lipids and the free fatty acid components of the lipids separate. Glycerol and alanine from muscle becomes substrate for hepatic gluconeogenesis. And then the free fatty acids go to the liver, and because of insulin deficiency, free fatty acids are incorporated into the mitochondrial matrix. You develop, you turn those free fatty acids into keto acids, and then because you have all of these excess keto acids, you develop acidosis. And so all of that together results in diabetic ketoacidosis. Usually the patient with DKA is a type 1 diabetic. They're volume depleted, they have electrolyte disturbances, they're acidotic, but they don't necessarily have profound hyperosmolarity. Whereas in the hyperglycemic hyperosmolar state that you see in older type 2 diabetics, you see more hyperosmolarity with that. So the anion gap is how we diagnose how severe an episode of DKA is. And an anion gap is seen in diabetic ketoacidosis, alcoholic acidosis, lactic acidosis, in uremia, methanol, ethanol toxicity, ethylene glycol, aspirin, paraaldehyde. So there's a number of different, there's a mnemonic that I remember, that I used to remember from medical school, but to recall all the different types of anion gap acidosis. But it's basically calculated by subtracting chloride plus the bicarb from the sodium. And the normal anion gap is under 12. Over that, you have an anion gap acidosis. In the correction phase of diabetic ketoacidosis, when you've given someone insulin and they're starting to improve, they'll shift from an anion gap acidosis to a non-anion gap hyperchloremic acidosis. So you can't just follow bicarb in the correction phase of DKA because it will fool you. The bicarb may remain relatively low, but if the anion gap is improving, you know you're getting better. So the ketone bodies that are seen in DKA are acetoacetate, beta-hydroxybutyrate, and acetone. And actually the primary ketone that's seen in DKA is the beta-hydroxybutyrate, and that's not one that you pick up by checking like urine ketones. You see it in the serum ketone studies that we do. So if you're following urine ketones, someone in DKA may not be all that positive. They may only be mildly positive. You have to do serum ketones to know that they're strongly positive. But to be honest, when I'm seeing a patient with DKA, I rarely even measure ketones. I follow the anion gap. And again, as you're correcting DKA, the component of ketones in the system will shift from beta-hydroxybutyrate to acetoacetate. So the urine strips, if you're following that in the correction of DKA, will become more positive for ketones as you're corrected. So we've just reviewed that. So what's the clinical presentation of diabetic ketoacidosis? Most of you are familiar with this. Of course, you've got the findings that are associated with the hyperglycemia, which is polyuria, polydipsia, and if it's profound, nausea, vomiting, weakness. You also see abdominal pain in diabetic ketoacidosis, which is something that you don't see if you're just hyperglycemic. Unphysical Kussmaul respirations, because you're breathing fast and you're trying to expel CO2 in an attempt to compensate from a respiratory standpoint for the metabolic acidosis. So you have you're attempting to develop a respiratory alkalosis as a compensation for the metabolic acidosis. The fruity breath, some people describe it as fruity. Some people describe it as like an almond sort of scent, but it's very characteristic. And I've gotten to where I can actually walk into the emergency room and I can tell if someone in the emergency room has DKA because I can just smell it from a long way away. Tachycardia, hypotension, poor skin turgor, etc. Hyperglycemia is one of the hallmarks of DKA unless you have an SGLT2 inhibitor on board. Because the SGLT2 inhibitors work independently of the actions of insulin, you can have a patient who has 0 insulin on board. The 3 drugs that are on the market, and I'm going to use the trade names because people are familiar with these, and I'm not because I'm selling anything, okay? But it's Farxiga, Invokana, and Jardiance, okay? They're great drugs. I use these drugs all the time in type 2 diabetes. But you do have to be aware that there is an increased risk for DKA. But because these drugs work independent of the actions of insulin, you can have a glucose, you can be in diabetic ketoacidosis and still be peeing off this glucose as a result of these drugs and have a glucose that's 150 when you've got a pH of 6.9. The worst case of diabetic ketoacidosis I've seen in the last 10 years was a patient of my own who was on one of these drugs, and she came in with nausea, vomiting, abdominal pain. I thought she had a GI bug. I put a line in her and gave her fluids in the office. She wasn't getting better, so I admitted her to the hospital, and when the first blood gas came back, it freaked me out because her pH was 6.8. And she had an anion gap of 30-something, and she was really, really sick and required bicarb, et cetera, et cetera. So just be aware of that. Potassium is always depleted in diabetic ketoacidosis. Most of your body's potassium is intracellular, and you have obligate urinary losses when you're just peeing like crazy. So you lose some of your potassium that way. But then when you're acidotic, hydrogen ions go into the cell, potassium ions come out, and then you pee off the potassium. So when you initially see the patient with diabetic ketoacidosis, they may have a normal potassium or even a slightly high potassium, but from an overall total body standpoint, they're actually potassium depleted, and you have to watch that really carefully. That's why monitoring basal metabolic profiles as you correct the DKA is important. Well, I'm going to skip that. So in DKA, there's usually something like a 7-liter deficit of water, a large deficit of sodium and potassium, and phosphate as well. I'm going to skip that too. The level of mental status aberration, obtundation, is typically related to how high your serum osmolarity is. I mean, if your glucose is 1,000 when you present with diabetic ketoacidosis, you're going to be sedated. You're going to be out of it. So there's that seems to be a high correlation. And the abdominal pain seems to be correlated with how acidotic you are. So if you see a patient in the ER who's got an elevated blood glucose and they're in abdominal pain, in addition to things like appendicitis and cholecystitis and things like that, think about diabetic ketoacidosis as well. So again, this is a chart showing that the lower your bicarb, in other words, the more acidotic you are, the more likely you are to have abdominal pain. So how do we treat DKA? The supportive therapy is replacement of fluid losses, replacement of electrolytes, detection and treatment of anything that precipitates DKA. And then there's also correction of the metabolic acidosis itself, which only occurs by replacing insulin. Fluid therapy, it's always safest to just go straight with normal saline. Even if someone presents with a sodium of 115 because their glucose is 1,000, that's really a pseudo-hyponatremia, and it's going to be safer to correct their fluid balance with just normal saline rather than using like hypertonic saline or something like that. Normal saline is usually the best thing. And then when the glucose gets under 250, I usually switch to half normal saline plus glucose. And these people typically require a lot of fluid. Again, when they present, a couple liters immediately, and then aggressive fluid hydration after that as well. Now, back in the late Cretaceous period, when I was a medical student, when we saw people with DKA in the emergency room, we actually didn't have the automated IV drip machines that we have now, and so the medical students or the residents would give just IV push insulin on an hourly basis as we were monitoring their glucoses. Typically these days when people come in, you start an IV insulin drip. And there are all kinds of different algorithms for how you increase or decrease the IV insulin based on hourly glucose checks. And at the end of the day, they all work. These patients need IV insulin, and you don't have to be in a rush to correct their hyperglycemia. Once you get IV insulin on board, they're going to do better. In fact, St. Vincent's has decided to system-wide implement a new DKA protocol where everybody that presents with DKA gets started on a rote IV insulin regimen that's based on their weight. Like if someone's 60 kilograms, you'd start at 0.1 units per kilogram per hour, which would be 6 units per hour. And then actually the nurse would give bolus IV insulin on an hourly or 2 hourly basis based on a sliding scale. And that's based on a protocol that was published in the ADA guidelines about 1.5 years ago. Again, potassium repletion is really important. If someone presents in DKA with a normal potassium, at that moment they probably need potassium replacement. So I usually put 20 milliequivalents of potassium in their fluid replacement right away, unless they're hyperkalemic when they present. You see phosphate depletion in DKA, but it's very unusual for you to really have to replace that. If the phosphorus gets dangerously low, you can substitute potassium chloride with potassium phosphate instead in the fluid. That's usually not something that's required. And bicarbonate administration, When I was a resident, the literature poo-pooed the idea of bicarbonate administration in DKA, saying, you know, if you just corrected the DKA, the bicarbonate would eventually return to normal, and that's true. But actually, people have found that if you have a severe degree of acidosis, the patient really does better if you supplement with bicarb. So if someone presents with a bicarb under 7.0, instead of giving normal saline, I'll give them half normal saline with an amp of bicarb and use that as their fluid repletion. Cerebral edema is one of the really dreaded and feared complications of the correction of diabetic ketoacidosis. And you see it in children probably more often than you see it in adults. But we don't precisely know why this happens, but when you're hyperosmolar, your brain cells produce what's called idiogenic osmoles, which are osmolaric molecules that keep the fluid inside the brain cells. And if you correct the diabetic ketoacidosis and the hyperosmolarity in the bloodstream and extracellular fluid too quickly, you have a hypotonic extracellular fluid and a hypertonic intracellular cytoplasm, and that creates a gradient, and the brain cells swell, and you get cerebral edema. And you can get a form of pontine myelinolysis that occurs that's potentially fatal or very debilitating. So the answer there is, again, to use, if you use normal saline and if you correct diabetic ketoacidosis methodically rather than trying to do it rapidly, people will generally do well. I've talked about all of these management pitfalls except for treating the underlying cause. Diabetic ketoacidosis can be prompted by someone just stopping their insulin or forgetting to take it, being non-compliant. But very often it's seen in the setting of some kind of infection. Pneumonia, gastroenteritis, typically a viral gastroenteritis is very common, UTI, skin and soft tissue infections, periodontal infections, perirectal infections. The last one is one that I always look for because I've been burned on this a couple of times. One of my patients comes in with DKA and they don't correct quickly, or they go back into DKA after a day and a half in the hospital. And finally, you know, we turn somebody over and look at their bottom, and there's this big perirectal abscess that we had ignored or hadn't discovered. So look for signs of infection and look for atypical infections. MI can precipitate diabetic ketoacidosis. Physiologic, psychological stress can. If someone has been knocked out in a fight and they haven't taken their medications, or been sedated, or they've been in a car accident and haven't taken their insulin, they can go into DKA. And then just remember SGLT2 inhibitors. Take a good medical history, make sure you know what medications people are on. We don't know why SGLT2s do this. We know that they increase glucagon levels, and you have elevated catecholamines and glucagon levels in DKA, and so that may be it, but we don't really know for sure. Okay, wow. Okay, myxedema coma. We don't see this very often these days because so many of us do routine TSHs in the office, and people don't get into this state before they get medical attention, but sometimes it happens when people forget their medication doesn't get placed in their pill box, or there's some kind of miscommunication. Someone has their thyroid taken out and they're supposed to get started on Synthroid on their way out of the hospital, but it doesn't happen. But we do see it every now and then. There are precipitating events, just like for DKA, myocardial infarction, infection, gastrointestinal hemorrhage, trauma, So with myxedema, you have decreased intracellular T3, which is the active form of thyroid hormone, results in several different end organ abnormalities, hypothermia, and you also get respiratory insufficiency, and it's very common to see a low O2 sat. So if someone presents obtunded and with a low O2 sat or a low PCO, a low O2, high PCO2, and even slightly acidotic, that actually may be myxedema coma. Decreased blood pressure. Because of increased vascular permeability, you get the typical intracellular, the typical edema that's associated with myxedema. Very puffy, doughy sort of skin, thick tongue, hypothermia, pericardial pleural effusions, ascites. And so you'll see a low free T3, a low free T4, and a high TSH. Now, if you guys are used to seeing sick, hospitalized patients, you're used to seeing something called euthyroid sick syndrome, where anybody who's ill develops a scenario where you have decreased conversion of T4 to T3, which is the active form of thyroid hormone. In fact, the T4 in critical illness is converted into reverse T3, which is like the mirror image of T3, but it's not functional. And so you'll have a low T3, and if the euthyroid sick syndrome is very profound, the T4 will drop, and even the TSH will start to come down. So in really severe illness, you can have this confusing scenario where you have a very low T3, very low or a lowish free T4, and a lowish TSH, and you don't know, is this pituitary failure or is this just euthyroid sick syndrome? And it can be hard to distinguish that. But classic myxedema coma is you're going to have a very high TSH, not just 20 or 30, 250, over 250, over the limits of their upper limits. So in a low T3 and eventually a low T4. You'll see often bradycardia. You can see complete heart block. You can see diffusely low voltages. And these people need to be treated carefully because the mortality of myxedema coma can be as high as 20%. And the hospitals don't like to use it because it's very expensive. But IV levothyroxine is really helpful, and usually you give a loading dose of 300 to 400 micrograms and then 50 to 100 micrograms daily. And the last time I used it at St. Vincent's, I had to get some special pharmacy approval, and I got to use it for 3 days. But it's apparently like a couple $1,000 a dose. It's very expensive. But it does help to get people started. One of the reasons that just giving oral thyroid hormone preparations in myxedema can be not that helpful is because not only do you have superficial edema, you actually have gut edema in myxedema, and your intestinal epithelium is edematous, and you don't even absorb from your gut the way you normally absorb. Some of these people need electrolytes. Be careful with sedation, and always be aware that these people may have other hormonal abnormalities. They may have adrenal insufficiency as well. So if there's any suspicion of adrenal insufficiency along with thyroid deficiency, you always replace the steroids before you replace the thyroid hormone, because if you give thyroid hormone when you're deficient in both, you precipitate an adrenal crisis. All right, so let's switch to thyroid storm. There's a misconception about what thyroid storm is. Thyroid storm is not just really bad hyperthyroidism. Thyroid storm is an event that occurs on top of an existing case of hyperthyroidism. You can have bad hyperthyroidism for a long, long time, and be very ill and never go into thyroid storm. You can be hyperthyroid for 1 week and then suddenly go into thyroid storm. So thyroid storm is hyperthyroidism plus hyperpyrexia or fever. You usually have a very profoundly hyperdynamic cardiac output state, and even to the point of having high output congestive heart failure, and then profound irritability or even psychosis. Precipitating factors, you've got someone who's already hyperthyroid to begin with, and you withdraw their antithyroid drugs, severe infection, DKA, MI, cardiac failure, surgery, trauma, especially manipulation of the thyroid bed can do it. So you've got someone who's hyperthyroid, you go to surgery without any kind of pre-treatment. The surgeon's obviously manipulating the thyroid bed during surgery. That can actually precipitate thyroid storm right there. So your free T4 and especially your free T3 are very, very elevated. A lot of the thyroid panels out there have a free T4, a total T3, which is useless, and a TSH. I always order a free T3, a free T4, and a TSH. You can be profoundly hyperthyroid and have a normal T4. And if you don't check the free T3, the free T3 may be sky high and have a suppressed TSH, but you're missing something if you don't get the free T3. So the lab findings are not necessarily that different. The difference is the setting. So the treatment of thyroid storm is the same, plus a little added as far as the treatment of hyperthyroidism. You're trying to reduce sympathetic outflow, you're trying to reduce the production and the release of thyroid hormone, and you're trying to prevent the peripheral conversion of T4 to T3. Supportive therapy with fluids, oxygen if necessary, if they're in heart failure, cooling if they're super hot. Don't use aspirin in these people because aspirin can displace thyroid hormone from albumin and other non-active binding sites and actually increase the available amount of thyroid hormone. Like, thanks a lot, don't need that. And then the specific measures are, from a sympathetic standpoint, blocking the beta blockade with oral propranolol or IV esmolol or IV propranolol pushes, antithyroid therapy with methimazole or propylthiouracil. These drugs block the incorporation of iodine onto the thyroid hormone molecule, but they also partially prevent conversion via the 5' deiodinase enzyme of T4 into T3. Interestingly, iodine, which is a component of active thyroid hormone, actually can be useful in blocking thyroid hormone production. If you give a lot of iodine, you can overwhelm the enzymes that are incorporating iodine into the thyroid hormone and shut down thyroid hormone production. So that's why a lot of surgeons will give patients iodine drops before they go for thyroid surgery. And then something that I always use in severe hyperthyroidism, but absolutely in thyroid storm, is steroids. Steroids are very helpful. And people aren't exactly sure why. It probably helps in peripheral conversion of T4 into T3, but it's certainly very helpful. Cholestyramine is sometimes used because it will actually bind thyroid hormone in the intestine and you poop it out. I haven't found it helpful myself, but all of the above are helpful. Prognosis used to be 100%. It's down to 30%, but it's still, people do die from thyroid storm. So you have to be very careful with this, people. If you see someone who's hyperthyroid, who has crackles at their bases, is a little bit febrile, you should be really scared and get that patient in the hospital. Okay. What's up next? Adrenal crisis. So adrenal crisis is typically going to happen in the setting of someone with a known diagnosis of Addison's disease who has some other event happen. They get sick, they forget their medicine, they're in a car accident, etc. Get an infection. The causes of primary adrenal insufficiency in the United States, it's autoimmune. It used to be in the United States, and certainly in Central Africa, it may still be infectious, tuberculosis. Certainly in Central Africa, with HIV being endemic, you've got coccidiomycosis and several other fungal organisms that can result in primary adrenal insufficiency. But you also see very commonly in HIV secondary adrenal insufficiency. You can have acute destruction of the adrenals with someone who's anticoagulated and they get acute adrenal necrosis. And then you can have secondary adrenal insufficiency when you have pituitary apoplexy, which we'll get to in a few minutes. But precipitating events, infection, MI, surgery without adrenal support. You especially have to be aware of if someone's having like a unilateral adrenalectomy, that if that adrenal is overactive, the other adrenal gland will be suppressed. So if you remove the overactive adrenal, the underactive adrenal will not just suddenly come to life. It takes a while, and you can develop acute adrenal insufficiency. And I've definitely seen that in people who don't even have signs of Cushing's syndrome. So when someone's going for adrenal surgery, I always do a very careful assessment beforehand for the possibility that they might have subtle or occult Cushing's. And then there are drugs, ketoconazole, drugs that interfere with steroid metabolism like Dilantin and rifampin can result in acute adrenal insufficiency. And then there are drugs that are used these days in cancer therapy, aminoglutathione and things like that, that can result in acute adrenal insufficiency. Clinical presentation is nausea, vomiting. Fever is almost classic for adrenal crisis. And these people can get a high temperature. And that's distinguished from the person with pituitary apoplexy, which they may have a very low cortisol, but they don't have a fever because they also don't have any thyroid hormone. But the patient with primary adrenal crisis or primary adrenal insufficiency who's in crisis typically will have a quite high fever. Dehydration, hypotension, shock, abdominal pain. One of the things that these people get is hyperpigmentation, and you can see it. The wrinkles of their hands look particularly dark. In my experience, they don't have to look tan or mahogany. I have a patient who has adrenal insufficiency, and she's got some Cherokee Indian in her background, and she literally turns she's mahogany when she is under-replaced with her adrenal hormone. I have other patients who, when they're under-replaced, they just get a kind of a dusky or almost a dirty appearance. The wrinkles around their neck and on their hands look dusky. But you can always detect hyperpigmentation in the buccal mucosa, under the tongue or on the cheeks. Hyponatremic, hyperkalemic. At our hospital, you don't get a cortisol level back immediately. So if someone comes in the emergency room and you think they're in adrenal crisis because of, they're hyponatremic and hyperkalemic, you treat them with steroids before you get the laboratory studies back. I'll give you all a case diagnosis. There's somebody that I know that developed profound weakness and almost collapsed on a walk. And when she was taken to the doctor, her sodium was 110, and I asked the doctor that was seeing her, said, do these people get SIADH? And she's like, I don't think so. I said, do these get adrenal insufficiency? And she was like, well, they can. And so we tested, and in fact, she was profoundly adrenally insufficient and did great on adrenal replacement. In fact, this person I'm talking about was one of my Welsh corgis, one of my dogs, who literally, when I was taking her on a walk, she collapsed. And I took her to the vet, and she had primary adrenal insufficiency. So, very odd. The ACTH stimulation test, again, you're going to be doing that later. You're not going to be doing that acutely because these people are potentially very sick. But if you can get a baseline ACTH, that may be very helpful because someone with primary adrenal insufficiency should have a quite elevated ACTH randomly. And I do that a lot. These people need steroids. They need hydrocortisone, and it's typically 100 milligrams IV Q6 to Q8, depending on how big they are and how sick they are. And you switch to orals when they can tolerate orals. And they typically need fluids. And if they truly have primary adrenal insufficiency, when they get switched to orals, they may also need mineralocorticoids because hydrocortisone or Cortef is primarily a glucocorticoid. It doesn't have that much mineralocorticoid effect. Pituitary apoplexy is a combination of profound hypothyroidism, a profound adrenal insufficiency because your pituitary is dead. And it typically happens in the setting of someone who has a pituitary tumor. It's usually a non-functional pituitary tumor that suddenly bleeds into itself. It can also happen in a condition called autoimmune hypophysitis, where you have an autoimmune destruction of the pituitary gland. And it can happen in someone with a normal gland, specifically, the most commonly in a pregnant woman who becomes very hypertensive with eclampsia during delivery, or alternatively becomes very hypovolemic during delivery because of blood loss, or in the setting of anticoagulation therapy. So any setting where the pituitary is terribly inflamed or dies, gets necrotic, this can occur. And these people almost always have a headache, and they almost always have a visual disturbance. They have a bitemporal hemianopsia. They lose their peripheral vision because your pituitary is right at your optic chiasm. It's swollen. You're pressing on the optic chiasm and you lose your peripheral fields. Cranial nerve 3 palsy can develop, and they can even get meningeal symptoms, neck stiffness, etc. So you do a CT scan of the head. If you've got an ugly looking pituitary that looks like it's bled into itself, you're going to treat these people with steroids and thyroid hormone, and you're going to consult a neurosurgeon because it can be really tricky as far as when that situation may need to be decompressed. Steroids, thyroid hormone, acute neurosurgical consultation. Long term, these people need assessment for diffuse hormone deficiencies and antidiuretic hormone deficiency. You usually don't see diabetes insipidus with pituitary apoplexy, except in this setting where someone's just had pituitary surgery. And you see DI transiently post-pituitary surgery, actually pretty commonly. And you're seeing urine outputs of over 3 liters a day with high serum osmolarity and inappropriately normal or low urine osmolarity. So it's someone, if your sodium's 150, you should be peeing out incredibly concentrated urine. But if your sodium's 150 and you're peeing out very dilute urine, you're probably missing antidiuretic hormone. And you just replace it with DDAVP, either sub-Q, IV, or actually we now have oral DDAVP. So I think I'm going to hit hypercalcemia as fast as I can and stop. But hypercalcemia is something that we see from time to time, and it's typically in the setting of someone who's been mildly hypercalcemic for a while, and then something happens. They get sick, they get a gastroenteritis and vomit and get very, very dehydrated, and they get acutely very hypercalcemic. Most of these people in our day and age have hyperparathyroidism in the setting of either solitary hyperparathyroidism or the hyperparathyroidism associated with multiple endocrine neoplasia syndrome, type 2A, which is parathyroid adenomas, medullary thyroid carcinoma, and pheochromocytoma. Okay, that's MEN2A. And you can also have solitary hyperparathyroidism. You can also have parathyroid carcinoma. You can have parathyroid hormone-related peptide, which is made by tumors, mostly neoplasms that are carcinomas, like carcinomas of the lung, renal cell. Renal cell carcinoma is very common. I've made a couple of diagnoses of renal cell carcinoma without even seeing the kidneys on CT when I had a patient who'd had a chest CT that showed nothing, and I knew they didn't have cervical cancer, but they were very hypercalcemic from PTHRP, and I said, this is probably going to be renal cell carcinoma, and sure enough it was. You can have a different form of hypercalcemia with someone who's got aggressive bone metastasis or myeloma, and then a different form again in granulomatous tumors or infections like sarcoid, tuberculosis, and lymphomas. These people are polyuric, polydipsic, dehydrated, they can have bone pain. Confusion is very, very common when you get a calcium over 13. They get anorexic and they get constipated. One of the hallmarks of severe hypercalcemia is a shortened QT interval, so that can be a clue on the EKG. And the workup is pretty easy. If someone comes in very hypercalcemic and their PTH is high, it's going to be, they have hyperparathyroidism, end of story. If they come in and the PTH is undetectable, you have to be worried about PTHRP or one of these, tumor-related forms of hypercalcemia. But beware of, quote, inappropriately normal PTHs. Parathyroid adenomas are like normal parathyroid tissue, but they have a different set point. So if you have hyperparathyroidism and your normal calcium is 12, if something happens, you get very dehydrated, your calcium goes up to 16, the parathyroid adenoma may suppress at that point, and the parathyroid level can come down. So when they present with a calcium of 16 or whatever, the PTH may be 20. And that can be confusing. It's like, well, that's a normal PTH, but the calcium's really high. But then you give them a lot of fluid, the calcium comes back down to 13, and then the PTH will go to 200. So just be aware of, at the time of presentation, if the PTH is inappropriately normal, they may still have hyperparathyroidism. The biggest thing to do in these people is volume repletion or expansion. And then if it's very high, if the calcium's over 13, you need to think about giving IV pamidronate, which is one of the bisphosphonates. Calcitonin used to be used, but is not these days. And then steroids are useful if you've got hypercalcemia that's from vitamin D toxicity, lymphoma, or granulomas, because the way they cause hypercalcemia is because the tumor and the infection, the granulomas convert 25-hydroxyvitamin D into 125-dihydroxyvitamin D, and that's how they produce hypercalcemia. Giving steroids shuts that down. So that's why it's useful. And if it's really severe, if someone comes in with a calcium of 20, you're going to be thinking about hemodialyzing them. So I'm actually going to stop there for questions because we're 5 till. I've really run through this fast, but I thought it would be fun to cover a lot of material. Any questions? All right, thanks.